Hello, everyone. Welcome to our lecture on post-operative pain, which is a key topic within our concept of comfort. So by the end of this lecture, you should have a clear understanding of how to assess, manage, and advocate for patients who are experiencing discomfort after surgery. So let's get started. So post-operative pain is an expected part of the early recovery process. It's typically most severe during the first 48 hours after surgery, and it may persist to some degree for several weeks. It's important to note here that sedatives and medications that are given during surgery can sometimes impair a patient's ability to accurately report their own pain levels. So this makes it really important for us as nurses to be able to assess nonverbal indicators of pain, such as changes in behavior, their vital signs, level of consciousness, and comparisons with preoperative baseline reports. So our primary nursing goal is to help patients achieve and maintain optimal comfort. So effective pain management relies on a combination of interventions, including things like drug therapy, proper positioning, relaxation techniques, and activities that can provide diversion. So there is a multimodal approach that usually gives us the best results. This is because different methods can complement one another. So whenever pain is well controlled, patients are then going to be more likely to cooperate with essential therapies and exercises, which can significantly reduce their risk of complications and promote faster rehab. So remember, regular assessments of the patient's pain and evaluating the effectiveness of our interventions are very important to be able to ensure comfort and to promote recovery. So in the early post-op period, being able to manage acute pain effectively is very important for our patient's recovery. Opioid analgesics are often used during the first 24 to 48 hours after surgery, and these medications can be administered on a round-the-clock schedule or via a PCA or patient-controlled analgesia system. So a PCA, in a way, allows patients to adjust their dose based on their pain levels, so they get a consistent pain relief while minimizing the risk of overdose with those built-in safety limits that are on our PCA pumps. So some of the common opioids are things like morphine and hydromorphone, which are typically injectable medications. And then we can also utilize things like codeine or combination drugs like oxycodone with aspirin or oxycodone with acetaminophen. And these are typically oral medications. So typically what happens as patients recover, the route of administration is shifted from that injectable or PCA to an oral medication. Non-opioid analgesics like NSAIDs, such as ketorolac or ibuprofen, are also highly effective, and they may be used alone or they may be used in combination with our opioids to help enhance pain control. Also, we can utilize anti-anxiety medications such as lorazepam to help address pain-related anxiety, help reduce muscle tension, and to help manage nausea. So whenever we're administering these pain medications, it's important for us as nurses to assess the type, the location, and the intensity of pain, both before and after intervention. And we typically do this using a 0 to 10 pain scale. It's also very important for us to monitor for any side effects, such as respiratory depression, hypotension, and nausea, which can typically be seen with opioids. And we also need to be prepared with opioid antagonists, such as naloxone, in the case of an overdose. So speaking of that, we really need to take care to avoid both over-medicating and under-medicating patients. So over-medication can lead to complications, while under-medication can just result in insufficient pain control, restlessness, or any other signs of distress. And as patients recover, dosages and medication frequency should be gradually reduced. So finally, we need to ensure that patients understand that short-term opioid use for acute pain management typically does not lead to addiction. We need to provide reassurance and education because this is going to be essential to help alleviate their concerns, especially when opioids are needed to facilitate participation in things like physical therapy or any other activities that are very important to recovery. Okay, so we're going to dig a little bit deeper into some of these different drugs that are used for managing post-op pain and kind of go over their associated nursing implications. So starting with our opioids. So these are widely used for acute pain management post-surgery. For morphine sulfate and hydromorphone hydrochloride, It's very important to monitor that respiratory rate and the blood pressure closely because respiratory depression can occur and it may require some immediate intervention. Also, we want to keep an eye on our GI motility and our urinary output because constipation and urinary retention are very common side effects of these medications. For codeine sulfate, monitoring that respiratory status is also important just due to the risk of, again, that respiratory depression. Constipation is another side effect to be aware of. A lot of times patients are going to be administered like stool softeners and things along with these opioid medications just to prevent constipation from occurring. Our next medication is butorphanol tartrate. So this requires monitoring of a patient's neurological status and they're looking for any changes in their level of consciousness because it can increase intracranial pressure. And respiratory depression is another potential risk. With our combination drugs like oxycodone and aspirin, we want to monitor for GI tolerance and function, as the aspirin component can irritate the stomach and cause GI bleeding. It's also important to assess coagulation studies because aspirin can influence bleeding times. For oxycodone with acetaminophen, we want to watch for blood pressure and respiratory status, as hypotension and respiratory depression can also occur. Like other opioids, constipation is still another common side effect. Next, we have our NSAIDs like ketorolac and ibuprofen. Either can be used, they may be used alone or in combination with opioids, as I previously mentioned. For ketorolac, we want to monitor for any GI bleeding, ulceration, and perforation. We also want to monitor the kidney function, especially in our older adults, because this medication can decrease urine output and it can cause other renal issues. Essentially, Toradol is metabolized through the kidneys, and that's why we really want to watch our kidneys. Kind of the same, ibuprofen can cause GI bleeding, ulceration, and perforation, so GI tolerance still needs to be assessed with ibuprofen as well as ketorolac. So by understanding these medications and monitoring for their specific side effects, we as nurses can ensure safer and more effective pain management for our patients. All right, so continuing with our drug therapy. So whenever we're managing our post-op pain, our pain medications that we use require very close monitoring just due to the risk of over and under medication. So nurses need to assess the type, location, and severity of pain both before and after administering medications. And we typically, again, use this by doing the 0 to 10 pain scale. And this just ensures consistent and objective evaluations. But when we talk about over-medication, especially with our opioid medications, we really want to be careful to monitor our patients' vital signs, particularly looking for hypotension and hypoventilation. So over-medication can result in respiratory depression, which can require immediate intervention with naloxone, otherwise known as Narcan. So naloxone is an opioid antagonist that very quickly reverses the acute effects of opioid overdose or respiratory depression. So it can be administered through various routes, including intranasal, intramuscular, intravenous, or subcutaneous injections. But one thing about this we need to remember is that our opioids are going to have a longer duration of action than our naloxone. So sometimes repeat doses may be necessary, and monitoring should continue every 15 to 30 minutes until the opioids effects have fully passed. For example, I've had a patient before. The nurse before me gave too much hydromorphone, and when I came in to do my beginning of shift assessment, the patient was in respiratory depression. I think she was breathing like 4 to 6 times a minute. And so we had to give Narcan, and she would kind of wake up for a few minutes, and then a little bit later she would kind of go back into that respiratory depression, which we ended up putting her on a Narcan drip or an infusion, and then she ended up going to ICU. But just use this as a cautionary tale. This patient came in, she tripped, fell off the curb, her complained of hip pain. She did not have a fractured hip, she just had like a contusion or a bruise. She was going to get pain medication and was going to get to go home, but because she was overdosed because of an issue with the physician's order, the nurse gave too much hydromorphone, and that patient ended up with an ICU stay. But anyway, so that's just a cautionary tale for you guys. So getting back to our presentation here. So again, over medication we really want to try to avoid, but on the other hand, under medication still poses a risk. So we again need to be attentive to nonverbal cues of pain, again, restlessness, confusion, behaviors like picking at bed linens, because all of these can indicate inadequate pain relief. So we may need to offer prescribed medications promptly, which can ensure the patient's vital signs are stable beforehand. So getting back to naloxone, it not only reverses respiratory depression, but it also brings the patient back into pain. It kind of gets rid of all of that pain relief that they have from the opioid analgesics that they were receiving. So we need to educate patients and families about its effects, as well as address any concerns about opioid use and how naloxone may be very important. So we need to reassure them, our patients, that even just short-term opioid therapy for acute pain is typically not going to be associated with addiction in the same way as a long-term misuse could. We need to stay vigilant and proactive in managing pain, as well as its potential complications. So as you can see, nurses play a pretty big role when it comes to drug therapy and our patient's safety during the postoperative period. All right, so the Pacera Opioid-Induced Sedation Scale, or POSS, is a very important tool for being able to assess sedation levels in patients who are receiving opioid therapy. So this scale helps nurses identify and address the risk of respiratory depression and potentially life-threatening complications. So the scale ranges from S to 4. So S stands for sleeping but easy to arouse. So in this case, no action is needed and the patient is in a safe state. 1 indicates the patient is awake and alert, which requires no intervention. 2 describes a patient who is occasionally drowsy but still easy to arouse. Again, no action is needed. And at 3, the patient becomes frequently drowsy and drifts off to sleep during conversation. So this is a critical point where the opioid dose must be decreased to prevent further sedation. And a 4 indicates that the patient is somnolent with minimal or no response to stimuli. And at this point, opioid therapy needs to be discontinued immediately, and we should strongly consider administering naloxone to help reverse the effects. So whenever we're administering opioids, as you can see now, it's very, very important to regularly assess the patient's respiratory rate and their level of consciousness. Using nursing judgment and discretion ensures patient safety and effective pain management. So always keep in mind that early intervention based on the POSS scale and just your nursing and your clinical judgment and critical thinking skills, all of this can help prevent more severe complications. So remember, maintaining our patient safety is the top priority, and we can utilize tools like the POSS scale to help empower us to be able to provide vigilant and informed care. All right, so for this slide, we're going to dig a little deeper in the best practices for managing a patient who is experiencing an opioid overdose, which, as we know, is a critical emergency that requires immediate intervention. So first, naloxone, which is an opioid antagonist, can be administered, again, via various routes, IV, intramuscular, subcutaneous, or intranasal spray. So among these, the IV route is going to be preferred in medications because it's going to have a faster onset. We always want to maintain an open airway while preparing to administer the naloxone. If the patient's respiratory function doesn't improve adequately, then again, naloxone doses can be repeated every couple of minutes, 2 to 3 minutes, based on the patient's response and the prescribed regimen. So we also need to administer supplemental oxygen if the patient becomes hypoxic or their respiration rate drops below 10 breaths per minute. Also, we want to have suction equipment ready because naloxone can induce vomiting, which increases the risk of aspiration, especially in our patients who are drowsy. My rule of thumb is if I'm going to give Narcan, go ahead and have suction or an MSS bag right there ready to go because it causes them to become very nauseated. Close monitoring is very important during the opioid reversal, so we want to keep monitoring the patient's vital signs and their level of consciousness every 10 to 15 minutes during that first hour after administration. Also, we want to remember that naloxone's duration of action is a lot shorter than that of opioids. So again, like I said earlier, usually these patients may need repeat doses. We also need to be aware of the possible side effects, including changes in blood pressure, tachycardia, and possible dysrhythmias. So we never want to leave our patient unattended until they are fully responsive. So keep in mind that reversing the opioid also reverses its analgesic effects. Like I said, we're taking away all of the good stuff that those pain medications give them. So this patient is going to be in some significant pain once we give this naloxone. So we want to assess and address this pain appropriately. Finally, the healthcare provider will need to evaluate whether additional doses of naloxone or other interventions are required, particularly 1 hour after the patient becomes fully responsive. So by following these evidence-based practices, we can help ensure the patient's safety and we can facilitate their recovery from an opioid overdose. All right, so moving on for our last slide here. So managing post-op pain involves more than just medication. Non-pharmacologic interventions can play a big role in promoting comfort and recovery as well. So we're going to go over some of the key strategies here. So first, a gentle massage can be used on stiff joints or on a sore back to help reduce discomfort, and it can promote relaxation. To help enhance the benefits of a gentle massage, the patient can assume a side lying position, and whoever's giving the massage can use smooth, gentle strokes with lotion to help increase blood flow to the area. However, we do want to avoid massaging the calves, just simply due to the risk of dislodging a clot, which could lead to a life-threatening emergency such as a pulmonary embolism. Relaxation techniques and diversion methods, such as listening to music, can also be helpful, especially during potentially painful procedures like dressing changes or injections. These strategies can help shift the focus, the patient's focus, so that they can reduce the perception of pain. We also want to encourage the patient to find a comfortable position and use ice therapy to help reduce swelling and to prevent inflammation. Whenever we're positioning the patient, cushioning and elevating painful areas can be helpful, but we do want to avoid placing pillows underneath the knees or raising that knee gatch on the bed, because this can restrict circulation and it can increase the risk of a venous embolism or DVT. It's also really important to control or to remove any noxious stimuli that can exacerbate pain. So providing a quiet, calming environment can improve the patient's overall comfort. We will also want to make sure that the patient gets adequate rest, because this can increase their tolerance to pain and it can support the healing process. And lastly, we may need to offer opportunities for things like meditation or mindfulness to help enhance relaxation and pain management. So these interventions, whenever they're used alongside our pharmacological therapies, can help provide a holistic approach to pain management, ensuring that our patient feels cared for and supported during their recovery post-operatively.